Welcome, everyone. Thank you very much, Dr. Saad, for this introduction. And I would like to thank you for this great platform that enables anesthetists and intensivists all around the globe to share their experiences together. Today, we proudly introduce eminent speakers in the field discussing very interesting topics. So please allow me to introduce our first speaker, Dr. Ahmed Amin Nasr. Dr. Ahmed has a vast experience in the field and worked in different countries around the globe. He is a Cairo University graduate. As a general practitioner, he worked for a few years in the Palestinian camps in Lebanon, graduated as anesthesiologist at the American University in Beirut. He got his fellowship from Ireland and followed it with pediatric anesthesia fellowship from Ontario, Canada, and Ottawa. Then a taste of working in Saudi Arabia, ending with King Faisal Specialist Hospital. Finally, he settled in the UK for the past 15 years, working for NHS. His last case while working at Royal Glamorgan Hospital was a laparotomy for a patient with a pacemaker. Today, Dr. Nasr is reviewing this very important topic about implantable cardiac electronic organizers, starting from permanent pacemakers to implantable cardioverter defibrillators and cardiac resynchronization therapy, how to identify these devices, how to deal with patients in the OR safely, electromagnetic interference, magnets, so many questions and so many challenges that Dr. Ahmed will highlight it in this lecture. Please, Dr. Ahmed, welcome.
Well, thank you so much. Thanks. Very good. Now, really, congratulations. It is the season of fasting. Wishing you very, very happy, fruitful, and successful fasting. You know, it gives me great pleasure to connect with all of you on the mega platform. So proud of its presence and of Dr. Saad Mahdi's determination, persistence, and consistency. A word of appreciation for Dr. Alaa Taha, who was behind this arrangement, and glad to have her as our moderator. I will take this chance to talk to you about implantable cardiac electronic organizers, the perioperative challenges, and new updates. You know, all hearts are born equal and free, regular and strong. But then some hearts become fatally slow or fast, or even failing, hence the need to be electronically organized. Bradycardia, disordered, sick sinus syndrome, or chronic complete heart block, or atrial fibrillation with block would require a pacemaker. Ischemic malignant ventricular tachycardia or ventricular fibrillation would necessitate overdrive pacing and defibrillation. Congestive heart failure and cardiomyopathy might lead to conduction delay and biventricular dyssynchrony that would necessitate biventricular resynchronization pacing. Both the heart and its implanted cardiac electronic organizer enter an inseparable bonding, best described as Catholic marriage, arranged by the cardiologist and device programmer, where unambiguously there is no return, all in oneness till the end. CEO senses and organizes the heart. Arrival of any seductive competitor would only cause confusion of this inextricable bonding, an issue of low fidelity noise clouding the pacemaker function, demanding vigilant presence of a pacemaker to prevent wrecking the whole machinery. Okay, so iCEO is nothing but a mini computer and a battery. And from there, some leads are taken out, going into the chambers of the heart. So you would have a right atrial lead from the computer to the right atrium, and then the right ventricular lead through the tricuspid valve, with or without the third ventricular lead, left ventricular lead, through the coronary sinus. Chest X-ray is a very important tool to find about pacemaker story. It tells its presence, circuit integrity, number of leads, anti-bradycardia or anti-tachycardia function. For example, this chest X-ray, you would find the can, which shows circuits and white opacity, which is the battery in the can. And then there are two leads. And you find the first lead going to the right atrium and the second lead to the right ventricle. So this is implantable pacemaker or atrioventricular implantable pacemaker. Here, there is a chest X-ray showing implantable cardioverter defibrillator or ICD. You can see that there are three compartments in the can: the circuit, the battery, and the capacitor, which carries the charge needed for defibrillation or anti-tachycardia pacing. Now, anti-tachycardia pacing means that you pace the heart with a higher rate than the ventricular rate in ventricular tachycardia at a shorter RR interval. So you take over this fast ventricular tachycardia and you bring it back to sinus rhythm. And also the defibrillator could deliver 30 to 45 joules from an added capacitor in the case of ventricular fibrillation, or if anti-tachycardia pacing fails. Shock passes between a defibrillator, two coils, as you can see them. Shock delivery is painful and utilizes more battery life, more than ATP. In anticipation of post-shock bradycardia, there is always an underlying pacemaker ready to take over in cases of bradycardia following shock. This chest X-ray shows biventricular lead. Here, you would find three leads, one for the right atrium, and one for the right ventricle, and one for the left ventricle, as I told you earlier, that passes through the coronary sinus into the anterior coronary vein on the left side. So why we do this? Because we want to pace the two ventricles at the same time to overcome the delay or the dyssynchrony between the two ventricles secondary to dilatation and prolongation of conduction. So this is what we call cardiac resynchronization therapy at pacing. You pace the two ventricles. Actually, this improved the ventricular remodeling and symptom improvement, and hence decrease the hospital stay. This is another CRTP where the defibrillator is added. So it is CRTP pacing and CRTP-D for defibrillator in case of malignant ventricular tachycardia or ventricular fibrillation. ECG is another important tool for showing the story of iCEOs. Midnight emergency cases, you will be lucky when you find only ECG besides chest X-ray. So all the time looking at X-ray, at the ECG, you should be able to define the spike, present or not, and its timing to the QRS complex, slim or wide. Pacing shows spike, which is followed by wide QRS because of the block, the bundle block, because you take from the right ventricle to the left ventricle through the whole myocardium, not through the left bundle branch. So you have bundle block, left bundle branch block, and wide QRS. If there is no spike, you would find no pacing, and the QRS most likely to be slim or wide if the underlying condition dictates that. Here we go. In the 60s, pacemakers were created rocking and asynchronous, pacing at regular intervals, in total disregard to myocardial potential, whether resting, depolarizing, or repolarizing. pacing spike might come through any spontaneous beat, creating problems if the heart is paced near the end of T repolarization wave. R on T could bully the heart into ventricular fibrillation. To be honest with you, extent of this pacemaker R on T threat was not well studied. However, it motivated creation of sensible pacemakers. Now, these are the sensible pacemakers, or what we call synchronous pacemaker. Synchronous pacing on reaching maturity, pacemakers got the feel of the heart before deciding to pace or not to pace. On ECG analysis, look at the spike versus QRS, slim or wide. Here at the first beat, you find that the pacemaker senses both atrium and ventricle, yielding the right of way to them. So the pacemaker is inhibited while the heart is allowed to do its job. Now, at the second beat, you find that the atrium is done well, but the ventricle did not. So the pacemaker will be triggered to pace the ventricle after a certain delay for very obvious reasons. Now, the third beat, you would find that the pacemaker, for a certain reason, did not sense the atrium or the ventricle, so it both paced both atrium and ventricle. On the fourth beat, you find that the atrium is paced, but the ventricle is not paced because the pacemaker was inhibited. ECG patterns in cardiac resynchronization. You could guess it. When you have when you pace the right ventricle, you have left bundle branch block. So you assume if you pace the left ventricle alone, you will have right bundle branch block. So if you pace both ventricles, you would find a kind of combined left bundle branch block and right bundle branch block showing as big R and big S in V1. Now, this is the weirdest classification ever, giving 5 letters to differentiate types of IPMs. Historically, all started with pacing. But strange enough, after successfully adding sensory function that determines a response, neither made its way to first and second letter. Besides, none at first letter makes no sense as the whole classification collapses. Also, triggered only pacemaker is physiologically impossible, as we agreed upon earlier that the pacemaker either inhibited or inhibited and trigger in the same time. So it's always either inhibited or inhibited and trigger IT. Now, if we stop sensing and stop responding, that will be DOO, because it's dually pacing the pacemaker, but not sensing any chamber and not responding, either inhibited or IT inhibited triggered. So that's an unliked figure. DO is unliked figure because of the R on T. That's in the cardiology arena. And also, if you are a trade unionist, you wouldn't like that because it means driver only operator, or we can mean it now pacing only operator. Now, rate modulation, it's kind of it's got an accelerometer that check or senses the movement of the patient. And of course, in anesthetics, this rate modulation will be idle because your patient is on the table. Now, biatrial pacing may prove futuristic. A simpler approach to understanding iCEOs has nothing to do with exams, but rather improves our understanding. It is intuitive to consider chamber sensing at first, second, planning response, then chamber paced, and at last, the off mode. So, the primary step is what is sensed? Is it atrium, A, ventricle, V, or atrioventricular, AV, or atriobiventricular ABV, or none at all, means it is becoming asynchronous pacemaker. The plan of response, it's either I inhibited or IT inhibited and triggered, or R modulating, or asynchronous mode, asynchronous response, which is actually planned by the computer of the pacemaker. Now we come to the actions of the pacemaker. First action is antibradycardia. Historically, that was the first function of the pacemaker. Antibradycardia pacemaker is atrial pacing, AP, ventricular pacing, or atrioventricular pacing, AVP. Now, resynchronization pacing or atriobiventricular pacing. Antitachycardia pacing, ICD, then combined CRT, PD, cardiac resynchronization therapy, PD, pacing, and defibrillation. At last, the off mode, which could be programmed by a programmer or done by bedside. This classification is simple and intuitive, as I think. Now, the off mode. Asynchronous IPM did not live long enough, as R on T was too intimidating. Sensory, function, and IT IPM response were added as a master program, while asynchronous pacing became a shadowy slave backup program. ICD master program joined the pack, and IT IPM became its slave program that would work in case of failure or stopping. So there is always a master program and slave program. And guess what? If you shut off the master program, you would find that the slave program is unleashed and in action. Now, let us shut off the IT IPM. When you shut off the IT IPM, there is always a threat of R on T that might precipitate ventricular fibrillation. So when we shut off the IT IPM, we add the defibrillation pads in order to be ready for defibrillation in case it happens. You can also shut the ICD, and then the IT IPM will be unleashed in case, and will be in function in case of bradycardia following the shock. Now, in case of malfunction, any computer malfunction, what would you do? Your first step is usually shutting down and then restarting the computer. Same applies, believe it or not, for pacemaker malfunction. Here we go. We have a pacemaker-induced re-entrant tachycardia, which is a pacemaker making an antegrade limb, and the atrioventricular node constitutes the retrograde limb. Shut down. You shut down this one here, it will become asynchronous mode and back to normal into asynchronous mode. So you just cured the pacemaker-induced tachycardia just by shutting down. Now, you put it on, it will be again the same as normal because the tachycardia was just a malfunction. Here we go. Another example of iCEO malfunction, sudden appearance of atrial flutter in a heart with an ICD. Then the ICD may sense the high ventricular rate as ventricular tachycardia, rightly so. So it starts to overdrive the ventricle, but when this fails, it will shock the heart which is very painful to the patient and could be more frequent. So it could be a torture to this patient. Immediately you shut down this ICD, leaving the ITIPM as new master program. Reprogram triggering ICD to higher ventricular rate, or use beta blocker, or take ICD away in case of persistent atrial flutter. Now, shutting down could be done through reprogramming by the programmer, or it could be done in emergency situation by the bedside, applying a magnet. Now, have you ever wondered how the screen of your laptop or your old flip phone go dormant once you close the device? The secret is reed switch, which is shown here in front of you. It's a ferromagnetic switch consisting of 2 reeds and 2 contact plates. If a magnet is applied to its periphery, contact blades become far apart, breaking the circuit as shown with the horseshoe magnet. Point of care shutdown is placing a magnet that will close the master program and unleash the backup mode. This is called the magnet off mode. To magnet or not to magnet? It's an everlasting question whenever iCEO makes its debut to operating room. Magnets come in 40 shades of colors, shapes. When the magnet is correctly placed, and notice it should be correctly placed over the device, beeping tones appear 1 second later and for 1 long minute. So you have to make sure you know how to apply this magnet, or at least you should have been rehearsed that. You should have rehearsed that before. And one might wonder when magnets find its way to advanced cardiac life support courses. In noisy operating room, we magnet to increase fidelity. If iCEO received an interrupting, cheap, seductive noise, smart magnet will light an indicator to guarantee appropriate placement. Anyone can magnet, so why can't we? This is the question now. Even Apple can magnet. iPhone 12 had been discovered to magnet the pacemaker and stop the master program and unleash the slave program. So I guess it's easy to use the magnet, especially if the noises are threatening us in theater. Now, in noisy operating theater, we magnet to increase fidelity. However, we live in a sea of electromagnetic waves, huge amount of electromagnetic waves, radio waves, microwaves, light, ionizing radiation, including ultraviolet rays, X-rays, gamma rays. All these rays are electromagnetic. So which one could be an interfering with us in theater? Diathermy in theater, we use radio frequency output 0.5 to 1 megahertz in 2 forms, either unipolar form or monopolar form, and you can find that the radio frequency electricity, or the radio frequency electromagnetic waves passes through the tiny forceps of the monopolar, where it is very concentrated, making vibrations of the ions of the tissues, frequent vibrations at a 0.5 to 1 megahertz, making huge heat. And this heat is used for coagulation and cutting, hence this bloodless surgery. However, the second or the exit of these waves are the diathermy pad. And you can see the yellow cone between the inlet and the exit, very wide, if you can imagine that on a human body. And that would increase the likelihood of interference with pacemaker. So it is really too noisy. On the other side, bipolar diathermy, where you have the two poles and the electricity passes through the two poles and the tissues in between. So you are concentrating everything between the two tiny weeny forceps and the tissues. So very, very infrequent interference. So it is minimal noise. Now, in everyday life, patients with pacemaker will construct a balance between their heart, their electronic device, and any noisy electromagnetic interference. In theater, this balance should be at its maximum because of added surgical stress, identified iatrogenic noise. Anaesthetist is guaranteeing this balance. A multidisciplinary approach and summoning all possible helps, patient history. Ask the patient why he had this pacemaker. Did he have a shock before? Cardiology input, mainly regarding pacemaker dependency. They insist on that, though it's never found in patient files. Programmer battery check 1 year for IPM is a must, but only 6 months for ICD as shocks exhaust battery faster. Talk to the surgeon and see what electrosurgery or what type of cautery they are using or diathermy. Beware, at midnight emergency cases, only surgery anesthetist bilateral approach is the only available choice. The issue of pacemaker dependency is a tricky one and complex, even with no agreed upon definition. Thank God it is rare. In a very study in 2007, they found only 2.1% out of 3,638 cases. They switched off the pacemaker looking for an intrinsic rhythm of 30 beats per minute. Now they restart the pacing if there is asystole for 5 seconds or with significant bradycardia symptoms. So one might wonder, is it time for operating room checking for pacemaker dependency? Can we do that? Can we just do it either in the operating room or even in the induction room, just putting the magnet and see whether this patient is going to develop intrinsic rhythm of 30 beats per minute or not? Or if there is bradycardia symptoms or asystole for more than 5 seconds, then we can take the magnet out and decide what we are going to do if it is pacemaker dependent. Anesthetist work preoperatively should focus on ECG, chest X-ray, as well as diathermy, noise, type, site, and form, and the magnet whereabouts. Get history, but then don't sweat over dependency unless unambiguously stated by the cardiologist. Identification cards never found. Other things as appropriate. Don't forget, it's always noise versus magnet. This algorithm, released in 2016 by British Journal of Anesthesia, seems to me very stiff and stark. Very stiff, and a stark reminder of my initial continuous failure with London Underground. A simpler and intuitive algorithm could be suggested as follows. Patient with implantable cardioverter defibrillator. If it is below the umbilicus, use monopolar. If it is above the umbilicus, use bipolar. And we agree that the bipolar would be unlikely to cause interference. However, if surgery is within 15 centimeter area, any electromagnetic interference may release shocks. So go ahead and magnet this patient. And if ventricular tachycardia or ventricular fibrillation appeared, just take the magnet away. Patient with implantable pacemaker, below umbilicus, it's monopolar. Above umbilicus, again, bipolar. Surgery less than 15 centimeter away, reprogram or magnet to get asynchronous IPM with precautionary defibrillation pads, as we agreed upon. In theater, with a magnet ready, the question is always when and how to magnet. Hopefully, you have rehearsed that before, attempting it for the first time in theater. Any bradycardia or noise-induced inhibition of the pacemaker. Any tachycardia, pacemaker-induced tachycardia or ventricular tachycardia. Shocking, ICD, frequent shocks. You just apply the magnet off mode. Post-operatively, it is routinely said, continue observing for any intruding seductive noise. But then someone might ask, why that? What sort of noise this patient is going to encounter on his way to recovery room or even intensive care unit? However, I would suggest, my guess is just hand the case over to cardiology to guarantee iCEO welfare. This happy man has got a pacemaker, and is he allowed to be watching Aurora, goddess of the dawn, at the northern pole, where the solar winds are trapped in the Earth's magnetosphere, resulting in this spectacular light? He fell and broke his left shoulder. How would you conduct anesthetics? Could we use his iPhone to check for electromagnetic interference out there or even in theater? They claim Electrosmart App is made for such purpose. And I tell you, Electrosmart App, if Apple release some secret about how to, instead of getting the magnet sensor, the electromagnet sensor, it could be done. It could be done. Or could we all retain, we can use a what you call it, electromagnetic field monitor to practically measure any electromagnetic interference or electromagnetic field in theater continuously, or using the improved iPhone for patients with or without pacemaker to check over electromagnetic field, or to raise awareness of people in theater about electromagnetic waves that we are swimming into it. And we might as well prove the pacemaker Hertzian comfort zone, 15 centimeter, the holy grail of 15 centimeter or 6 inches. We can prove that by this. And notice that I called Hertzian comfort zone. Hertz is the one who actually described and made the first experiment to see how electromagnetic waves can move from one source to another. Now, at the end, I should thank you so much, and I'm looking forward for your questions and your comments. Thank you so much.
Thank you very much, Dr. Ahmed, for this very comprehensive and informed presentation.
surgery is within 15 centimeter area, any electromagnetic interference may release shocks. So go ahead and magnet this patient. And if ventricular tachycardia or ventricular fibrillation appeared, just take the magnet away. Patient with implantable pacemaker, below umbilicus, it's monopolar. Above umbilicus, again, bipolar. Surgery less than 15 centimeter away, reprogram or magnet to get asynchronous IPM with precautionary defibrillation pads, as we agreed upon. In theater, with a magnet ready, the question is always when and how to magnet. Hopefully, you have rehearsed that before, attempting it for the first time in theater. Any bradycardia or noise-induced inhibition of the pacemaker. Any tachycardia, pacemaker-induced tachycardia or ventricular tachycardia. Shocking, ICD, frequent shocks. You just apply the magnet off mode. Post-operatively, it is routinely said continue observing for any intruding seductive noise. But then someone might ask, why that? What sort of noise this patient is going to encounter on his way to recovery room or even intensive care unit? However, I would suggest, my guess is just hand the case over to cardiology to guarantee iCEO welfare. This happy man has got a pacemaker, and is he allowed to be watching Aurora, goddess of the dawn, at the northern pole, where the solar winds are trapped in the Earth's magnetosphere, resulting in this spectacular light? He fell and broke his left shoulder. How would you conduct anesthetics? Could we use his iPhone to check for electromagnetic interference out there or even in theater? They claim Electrosmart App is made for such purpose. And I tell you, Electrosmart App, if Apple release some secret about how to, instead of getting the magnet sensor, the electromagnet sensor, it could be done. It could be done. Or could we all retain, we can use a what you call it, electromagnetic field monitor to practically measure any electromagnetic interference or electromagnetic field in theater continuously, or using the improved iPhone for patients with or without pacemaker to check over electromagnetic field, or to raise awareness of people in theater about electromagnetic waves that we are swimming into it. And we might as well prove the pacemaker Hertzian comfort zone, 15 centimeter, the holy grail of 15 centimeter or 6 inches. We can prove that by this. And notice that I called Hertzian comfort zone. Hertz is the one who actually described and made the first experiment to see how electromagnetic waves can move from one source to another. Now, at the end, I should thank you so much, and I'm looking forward for your questions and your comments. Thank you so much.
Thank you very much, Dr. Ahmed, for this very comprehensive and informed presentation. You took us through a journey and started from permanent pacemakers toward cardiac resynchronization therapy. And also you mentioned the role of magnet and electromagnetic interference, which was clearly displayed. How about the role of MRI on chest surgery?
Okay, well, thank you so much. For MRI, actually, MRI is a big no for pacemaker, because we agreed that any application of magnet, on that reed switch, what it will do, it will make it off mode and goes for the asynchronous mode. So besides as well, what happens if it is, I know it is implantable, but it might make some sort of movement towards a magnet that might dislocate the leads. So it is a big no. However, they described different switch for the pacemaker called Hall effect sensor. The Hall effect sensor is that they got the pacemaker and then they applied the magnet in the pacemaker or over the pacemaker. But instead of having a magnet inside the pacemaker like a reed switch, they put some sort of circuits that these circuits will react to the magnet and interrupt the circuit and unleash the asynchronous mode. So magnet over magnet, and you cannot take the magnet out of the pacemaker because it is implantable. But magnet over electricity, you can reprogram the pacemaker before going into the MRI. So when you apply the magnet on this patient, on the pacemaker will not will ignore the magnet. All right. However, that means another point as well, that all the components of the pacemaker should be non-ferromagnetic. So A, non-ferromagnetic components of the pacemaker, and B, no reed switch, but Hall effect sensor. And I think this is what you call MRI safe conditional. So I think it's you go whenever you are in a hospital, you go with their protocol. If they are still going off a reed switch, then these patients should not be in MRI. If Hall effect sensor and ferromagnetic free pacemaker, you can go to the MRI. Now, to be honest, I didn't talk about alternatives to electrosurgery. There are many alternatives to electrosurgery. Electrosurgery with diathermy using radio frequency. You can use for you ask it for chest
surgery.
Chest surgery. Okay. Yes. Now, as an alternative to electrosurgery, you can use precision cautery laser excision. Laser stands for light amplification of simulated emission of radiation. Certain radiation, you amplify this certain radiation, you get the laser. Now, the laser photocoagulation is well used in eye surgery and in lung surgery. So no electromagnetic interference. However, they just brought the pacemakers and brought the laser, and they used both together, even in vitro, kind of in vitro, and also in vivo. So they settled the question of laser, that it is not contraindication to pacemaker. In eye surgery, it's used, lung parenchyma, in video-assisted transthoracic surgery. It's used very well. Now, you can ask me a very simple question, why they can use that everywhere in any patient with a pacemaker. You know, the coagulation cutting is a surgical entity. And it doesn't depend only on the electromagnetic waves you're using. It depends on the structure you are using itself. Are we still on?
Yes.
Oh, okay. Structure of the tissues, amount of water, presence of tendons. So lung is very easy managed with laser, but some certain other tissues might not be managed with that.
Mhm.
Of course, that needs surgical opinion regarding this. I'm not into that, but however, electro radio frequency is followed by microwave on the electromagnetic scale. Remember electromagnetic scale? I told you there is light in middle, and before light, low frequency is like radio frequency and microwave. We can use microwave in uh, in
Inspections.
with pacemaker.
Mhm.
However, again, because it is very near to the radio frequency radio frequency waves, it also might track the pacemaker. So you have to make sure whenever you are working with uh, microwave coagulation technique that it is 15 centimeter away from the ICD and IPM. And well, if there is shock, you apply by ICD, you apply the magnet. If there is any problem with bradycardia, you apply the magnet as well. So it's always kind of noise versus um, using of electromagnetic interference versus tissue preferences. It's kind of to be honest, the indication of diathermy is not the pacemaker. It is the type of the tissue itself. So that what dictates the type of diathermy, and we have to work around that. Okay. Now there is another high frequency ultrasound energy. Now we all have been very happy with ultrasound energy because it is not electromagnetic waves. Okay, fantastic. It wouldn't affect the pacemaker, but then no, it does affect the pacemaker. It might cause single beat inhibition of pacing. Besides, it might cause direct component damage. The ultrasound energy, just imagine a high sound on your ear. It can move your eardrum and can make rupture of the eardrum by moving. So it can also do that for the components of the pacemaker. So direct component damage if it's got direct hit. So again, not within 15 centimeter from the pacemaker. So you can use high frequency ultrasound energy. All right. Now, continuing with ultrasound or continuing with sound, extracorporeal shock wave lithotripsy again can cause direct damage. You see this cup is shattered. The glass is shattered by the sound. So that could happen again to the pacemaker if it's got direct hit. So you have to focus the extracorporeal shock wave away from the pacemaker. So of course, then we are talking about the left kidney thing, left kidney work or left water work, lithotripsy. So you have to make sure that you don't get the focus near to the pacemaker. And also the ICD should be disabled. With ECT, again, the electricity is coming between the two poles on that great actor here, on the head of that great actor. So it's very away from the pacemaker. However, the patient might move violently. That wouldn't happen if you give saxamsonium or you give rock uranium. So in that case, I don't think you need, if you are guaranteeing that the patient is not moving or paralyzed, I think it's okay to take it easy with the iCEOs. However, if you're not, so you can disable the ICD, but the pacemaker, you don't need to do anything to the pacemaker. Only ICD disabled to not to have shock. So as a matter of fact, you don't want to shock the patient twice. It's enough for his shock on the nervous shock. Now, radiation therapy, we said that again, the light between the non-ionizing radiation and ionizing radiation. The ionizing radiation, including ultraviolet rays and radiation therapy. With radiation therapy, there is no electromagnetic interference at all. The frequency is very far from being tracked by the pacemakers, right? However, it can have a direct damage as well, especially with continuous cumulative dose of radiotherapy. So if you can guarantee appropriate shielding, that's fine. If you cannot, then you might think of relocating the generator or the pacemaker. Does this answer most of your questions, Alaa?
Yes, sure. Thank you, Dr. Nasr, for this very comprehensive lecture. And thanks for the tips for anesthetizing the patients with pacemaker safely while using the bipolar, monopolar, different types of radiation and laser, ultrasound as well. So thank you very much.
Cheers.
You too. Is there any other questions from the attendees? There was just one question and you answered it about the ECT.
Yes, okay.
Okay. So I guess no more questions for now.
Okay, I'm off the hook. Thank you.
Okay.
Okay.
Sorry, Dr. Ahmed, sorry, I have a question about the regular ultrasound. Ultrasound used for regional anesthesia and pain management.
Yes.
Is there any effect if you use the machine, probe machine near the cardiac device, or any problem with that? Or you? Because usually we just will return back to go for regional anesthesia if we find a problem for this patient.
Yes, yes, yes.
Ultrasound have a
Well,
problem?
it's a very good question, actually. I didn't come across it. And however, I'm even thinking of not only local regional anesthetic, I'm thinking of cardiac echo. Is it possible to do cardiac echo with a pacemaker? And I'm sure it is possible. So I'm sure it is possible through my cases where I have been working with. Yeah, I don't think I didn't come across it, but I can tell you I don't think it has no effect. It is sound and it is ultrasound, and probably with not high energy enough like the lithotripsy or the ultrasound precision coagulation and cutting. So yeah, I think it is. I'm sorry for my first response. But now my second and last response, I don't think it affects it. No, I don't think. You can safely use it because they safely use the echocardiogram or echo for the heart while this patient has got pacemaker.
Okay. Where's Dr. Yasser? I guess he's muted. Okay. Thank you, Dr. Ahmed, for this.